Hey guys, welcome back to the channel. This is Side Dental Vlogs, and today we are going to talk about the most important and easy RCT, that is anterior tooth RCT. We often find it very easy and we think in our minds, wow, we have got the anterior RCT, jaldi khatam ho jayega, it will finish within 20 minutes or half an hour. But never finish the single sitting RCT of upper anterior tooth. Even if you are doing a single sitting RCT, you have to take time and do lot of irrigation. See, whenever we are doing anterior RCT, we have to see what is the age of the patient and what is the reason for the RCT. Okay, so maximum anterior RCT, we often see that patient has got a trauma and class 3 cavity, class 3 fracture and Ellis class 3 fracture, which involves the enamel, dentin and pulp. So when the pulp is exposed, we are doing the RCT. So even if it is a carious tooth, we are doing a RCT. Even if it is a traumatic tooth, we are doing a RCT. Even the patient had received trauma 10 years back, then we are also doing an RCT over that tooth. That also depends how many number of sittings you are going to give to that particular tooth. Suppose the tooth is carious and just involve the pulp and it's a pulpitis case, you can do a single sitting RCT. But mind me guys, according to Cohen, each and every canal should be irrigated with at least 40 ml of sodium hypochlorite solution, 5%. That means one syringe what you are using in India is around 2.5 ml. So you can imagine how many syringes of that 2.5 ml you have to fill for each canal. That is approximately going to be 20 syringes of full hypochlorite inside the canal. So that is the thing, like just think about yourself how much time you are irrigating, right? We are irrigating hardly 2 times, 4 times, 6 times, but while doing the RCT at least 12 to 13 times you have to irrigate the canal with sodium hypochlorite. Then only you can say to the patient that this tooth is gonna stay almost for more than 10 years. So what we do is we use a K file. Okay, we reach the apex 15, 20, 25, even if you are doing it with the K file. If you are doing with the pro taper, you are doing S6, S1, S2, F1, F2, okay, maximum, and you thought we have prepared the canal. But guys, the canal is circumferential, it's a 3D canal, right? And the most of the nerve endings, the most of the inflammation happens at the apical 1/3 of the tooth. Am I right, guys? So at the apical 1/3 of the tooth, if you have prepared it, you have prepared the entire tooth, but if you still don't prepare the apical 1/3 and with instrumentation only, it is very difficult. So you have to add chemical irrigants like EDTA, and you also have to use sodium hypochlorite and chlorhexidine. So make sure, even if you are doing a single sitting RCT for upper anterior tooth, do it very sincerely and irrigate 12 to 13 to 14 times before doing the final obturation. If there is a trauma case, I recommend that minimum you have to wait for 10 days to see what kind of reaction the patient is getting. The patient is getting any kind of inflammation, so what usually happens is, after finishing the RCT, patient has no symptoms till 6 months, and after 7 months or so, patient will start getting some kind of periradicular radiolucency at the apex of the tooth, and which may convert into a cyst because already the patient has got a trauma. So in traumatic cases, it's always advisable to give calcium hydroxide intracanal medicaments before doing the final obturation. So in this video, what we have learned is, basically we have to do a good RCT of the upper anterior tooth, and we have to do the apical gauging also. Apical gauging is basically you have to see what is the diameter at the apex, and there is an apical gauge which is made of, the company name is Dentsply, and with that you have to do the gauging. The gauging process I'll also explain in another video how to do the apical gauging of teeth while doing the RCT. So at the apex, your GP should be snug fit, right? It should be totally compact. Your entire canal should be totally compact so that no irritants and microbes can enter inside the canal from whatever space it may find. If you have prepared a canal which is actually the width of the canal is 45 or 50, and you have only prepared till 25, and you insert a thin GP inside the canal. So what is happening? Basically you are in your X-ray, oh, it's very nice RCT. What happens actually is, you are not tightly compacting the canal with the gutta perca. Full canal has to be tightly sealed with the gutta perca, with proper BMP, with proper irrigation. Then only it will be a successful RCT, and you can confidently tell the patient that this RCT is going to stay for more than 10 years and there are less chances of failure. So whenever you're doing the anterior RCT, do it wholeheartedly, and ऐसा नहीं कि आपको 2 दिन में खत्म करना है. Tell the patient it's going to take time because this case is a traumatic case or whatever infected case. So always think before doing single sitting RCTs whether it is feasible or not. So if you like this video, please do like, share and subscribe to this channel, and you can join me in Insta as well, Sai_dental. Till then, take care, have a very good day. Bye bye.